Moodle, Sean? It's in the Dropbox. It's called Lecture 12, something, something. All right, so last lecture of the semester. Oh my God. I'm as relieved as you are.
I didn't say I was relieved.
All right, what are you then? Sad to see me leave?
You're not going nowhere. You got
Well, some of us might see you in the hall because you're teaching.
Yeah.
The
Yeah, and we'll be in a completely different environment.
That's good or
What does that mean?
Yeah.
What? It'll be fall. I don't know. Different class.
Oh,
Different shit to talk about. That's what I meant. No. I'm hoping to see some of you in my practicum class. It'd be great. What? I teach them both. So last year I taught bachelor students in the fall and associates in the spring, but I don't know if that's going to be the same.
They told us there's 3 people teaching it.
Yep. So it'll be myself, Peter Basto, and Bill Wayner, Professor Wayner. And I believe there are twice as many bachelor students as associates.
That's what I was thinking. I think they're going to split the bachelors between you and Bill. I think. That's what I would assume.
Correct.
In charge of us.
Well, what will happen is that everybody will rotate. So whoever I have in the fall semester, I will not have in the spring. Professor Wayner will have both bachelor's groups. So I will have one bachelor's group and the other one that Peter does is the associates. At least that's the way it worked out in the spring. So all bachelor students here, so there's probably a 50-50 chance you'll end up in my fall practicum if the same semester kind of thing plays out as it did last year. So hope to see you guys there. If not, I'll see you at the end of the semester when we have our little get-together. It's fun. Faye can tell you. Yeah, we do. Yeah. No, at a restaurant. Well, someplace nearby. Whatever you want to buy. Yeah. Good question, though. Always worth checking out if there's some freebies. Yeah. All right. So I'm going to actually be relying on some people that took practicum already to talk a little bit about the topic that we have to talk about tonight. So we're going to talk about burnout for a little while, and then we're going to talk about the Drake article. All right. So we talk about burnout in the curriculum for practicum because it is pretty important. What's up with these colors? Ouchie. Yeah. So I'm using Professor Basso's PowerPoint. I made my own in my own typical Derek minimalism. And then I said, let me take a look at Professor Basso's. And his had these nice colors and boxes. And it had all of my content. So I'm like, I'm going to go with his tonight. I'm going to wow your eyes with some pictorials. So why are people burnt out in this field? I was thinking about this. What?
No, I said man.
I didn't hear what you said a second time.
No, I said, you said why are people burnt
Yes.
out? I was like, man.
Yeah. Okay. Well, exactly. You can name, there's probably a big list of reasons. Are you raising your hand or stretching?
Oh,
What are you going to say?
Well, because it's not on there. I think a lot of us don't practice enough self-care.
Yeah. Very good. Good point. So I was thinking on the way here, because I was thinking about this lecture as I was driving in, thinking about burnout and how I used to deal with it when I was working in the field as a supervisor and then as I was a direct care staff. And one thing I can say about the field that is one of the positives is my understanding is people get a little bit more personal time than they would get in a comparable position in other fields that pay, same range, same pay scale. They get a few extra days. The theory being that direct line staff and supervisory staff need a few extra days for mental health, self-care, as Megan said. So when I was driving in, I was thinking like, yeah, when I was working in the field, I used to take a mental health day probably once a quarter, once every 3 months or so. I would be a day I'd wake up and be like, I am just not in the right frame of mind to be helping people today. And fortunately, I mean, I could sort of mitigate it. Like there may be days where I didn't feel like that, but I knew we were down 7 staff, and it's like, all right, I can't, this can't be the day that I do this. You know, sometimes it worked out, it coincided with there being really good staff coverage, and I could sort of, you know, be like, guys, I might need a day off. And I compare it to my work here, and I think I've taken 1 mental health day in 4 years working here. And it wasn't because I was stressed out about the job. It was mental health for a personal issue. And it was like I was too much dealing with that to consider working that day. So yeah, this job is a little less stressful. You guys stress me out a little, but don't need to be taking mental health days for it. Yeah, I know, exactly. That's what they pay me for. But it's a completely different world when I was working in the mental health field. And I took those days because I needed them, and you should feel fine taking them too. And again, certain times you're just gonna have to buckle down, I think. But they're there because we need them. So when we feel like we're being rejected because we want to provide help and the person that we're working with doesn't want it, or people are being belligerent, sometimes people just get an attitude with you for no reason. And that happens outside of the field too, I'm sure. And you get burnt out on that. You deal with working with people that are unmotivated. And this is a classic sign when you feel like you're working harder than the person. I remember working with a person in our practicum class this past spring. And they were working with an individual who's a focused person who was just said all the right things about wanting the help, but then her actions betrayed her words, right? It's like, yeah, I'm going to do that. Yeah, I'm going to do that and this, this, and this. And then she'd show up next week and it's like, so did you do all those things? No. And then have a million excuses. And the person would feel like, especially because they were documenting it for class, you have the extra burden of like showing that they're helping out the person. And here's the person saying, yeah, sure, I'm going to do this, this, and this. And say, no, I'm actually not. It feels really crappy when you feel like you're doing more work for the person than they're doing for themselves. And when you feel that way, it's a good sign that either you're dealing with burnout, you're feeling burnt out, or the person generally, you need to have what I would call the come to Jesus talk with the person to be like, what are we doing here? Like, you're here, you're in this program, you're here voluntarily, hopefully. You say you're working on this goal, but your behaviors are saying, it's like that motivational interview and stuff we've been talking about the last few weeks. So yeah, the unmotivation needs to be addressed. And sometimes you're just not in the mood. You're just not in the right mindset to address it that day. Dealing with people that are insincere, people you work with that are avoidant. All of these things can make you feel like, why the hell am I doing this? Nobody seems to be benefiting. If they don't want to get better, why should I help them get better? And this creates distrust, skepticism. So the next time the person says, yes, I swear, I'm going to do X, Y, and Z this time. And you're going to be like, I'm not feeling optimistic about this. And we know optimism, one of the core values of psych rehab. And when you start to lose it, it becomes a little contagious. I could speak from experience. Morale is really dependent on sort of everybody having this cohesive optimism, collectiveness. And when one person loses it, when one person feels and portrays this distrust and skepticism about the potential for people's recovery, or that people are going to follow through on what they say they're going to do, it sort of spreads like a cancer to other people. And it's just hard to maintain that optimistic, come on guys, we can do this attitude that's really needed in some or many mental health programs. It makes it harder when one person is not really demonstrating that value. All right. So we need to avoid blaming people, but how do we deal with that? Oh, one more point. When we assign blame, and it may even be non-intentional on our part as practitioners, but the body language belies us, sort of, and our distrust and skepticism come through in our interactions with the people we're working with. The people themselves end up internalizing the blame. It's like, oh, this person's pissed at me now. It's like, oh, I'm such a, should have done this, or, ends up getting down on themselves, and it hinders the recovery process even further because it's going to take them even longer to now potentially work through that issue when the person that they had been depending on to sort of carry that optimism for them through the times when they may be struggling to hold it themselves. And that is something I've found people either have or they don't in this field. If they feel or sense that you are in this camp right here, they feel like they caused it. It's their fault. They're bad people. And that's going to hurt the therapeutic relationship, and that's going to hurt the recovery process, the chances of real process happening. Are you recording this? Yeah. If these microphones working? Yeah, see if you can hear me well in the other room. Okay, so when we get this way, sometimes the tendency might be to assign blame overly on one disorder than the other. It's like, oh, if they could only get past, these voices that they're hearing, or, if they could only get this substance abuse under control, everything else would probably work out for them, and when our efforts to assist in the area that they're really struggling with are not reciprocated, we might start to lose our focus on this idea that both disorders are in fact primary, and both come, oh, sorry, Peter does this so differently. Whoa, how did that happen? Okay, yeah, they disappeared, right? So you better write them when they're still there. All right, so there's 3 reasons. So there's a hereditary component present in both disorders, right? What does that mean? It can't. That's not what it means, but you're right.
I was so focused on watching the words disappear that
It's so weird. I don't understand it. Yes. So what did it say up there? Hereditary component.
This denial common point very
Yes, denial is common. If you don't remember anything else. All right. Yes. Thank you for bringing us back. So the biological component relates to the hereditariness of mental illness. If you, yes? It might be. I wouldn't put it anything past this slide. Yes, probably. This is the trippiest PowerPoint I've come across in a while. All right, so hereditary component is present in both, right? Substance abuse runs in families too, along with mental illness. These are 2 separate illnesses, and denial is common among both, right? Mental illness can take years to develop that insight into knowing, especially with thought disorders, that there's actually something wrong with me. It's not you. And when it comes to substance abuse, we know about the stages of change and the stages of treatment. That very first stage of both, pre-contemplation or the engagement stage. No, we should be expecting people to be like, I don't have a problem. I don't even know why I'm here right now. How's it sound?
Sound good there.
All right. So let's hope these all stay on the slide. So what are the challenges that people face? And the most challenging people that we deal with often tend to be somewhat neglected, I think, amongst the practitioner field. So I had this in my other slide. It didn't make it on its way to Peter's slide. You're going to hear from your supervisors, maybe, again, the former interns going to have something to say about this. You're going to hear, you know, shouldn't play favorites, you know, treat everyone equally, and that's absolutely true. The fact of the matter is we're human beings, and we develop relationships with people, and we do have favorites, and we have people that are not our favorites, right? Just like in this class, right? And in life, your family members, you're going to have your favorites, and you're going to have your, I still love them, not my favorite. So this is something to just, I found, you know, it's not worth it to tell people that this doesn't happen or you shouldn't let it happen because, again, we're humans. So I'm giving you the advanced notes here. It's like, okay, we're going to get past the acceptance factor that you're going to have your favorites. I mean, they're the part of the reason you're in the field is because you're going to have those relationships and you're going to get so much out of them, as much as the person that you're helping gets from you, and learn things about yourselves. So that's why I think it's important to just sort of accept this as humans, that we and embrace, like, you know, we're going to have special bonds with people. And that's why the caseload system, I think, kind of works in a lot of ways. You know, when you have people that you're sort of responsible for, a lot of times those relationships are the difference between somebody kind of staying stagnant in the program and just kind of getting by and subsisting. The difference between that and somebody actually rehabilitating and growing and going through the recovery process. So that being said, once we kind of come to terms with this, it now falls upon us, sort of ethically speaking, to know when this is happening and to kind of make a conscious effort to reach out to the people that we know we won't naturally have those bonds with as strongly with as our favorites, yet still need just as much, and in a lot of cases more help. Anyone that's worked have anything to say about that? What?
The person that challenges me the most, that I like the least, is the one that needs the most help.
Yeah.
As far as my caseload is concerned.
Mm-hmm.
I don't like him. I don't like his attitude. But when I read this, I was thinking to myself, and a lot of the motivational interviewing stuff that you read was right in the forefront of my mind, saying, wow, if I changed my perspective, I could help him by looking at him differently and looking at the way that I'm interacting with him.
Yeah. And these are things to spend time with your supervisor to kind of process these feelings, because that's what I found too, Faye, is after figuring out, it's like, this person really gets under my skin, or I can't stand it when this person talks at me and I know that they're not really going to follow through. You know, they're just blowing smoke up my ass. But inevitably, I often found that those people were the ones I learned the most from in terms of getting better as a practitioner, and using skills that I don't normally use because I am being challenged in that way. It's like, let me try this, because the things I use on 97% of everybody else, interventions 1, 2, 3, 4, and 5, haven't worked with this person. So now I got to pull out some other tricks. Yeah. Anyone else? Anything to say about this? So the most challenging people, some of these are some of the common factors you see. Cognitive issues. Horribly limiting to people that have trouble with being able to pay attention for long periods of time, or sit still, or focus, or have a decent short-term memory. You know, they're behind the 8 ball in everything they do because it's going to take that much longer. So you might feel like, the progress is not there that I'm seeing with Joe. Well, that's because Joe doesn't have the cognitive limitations that Larry does. And so if we can accept that, we can know it's like, you know, if it's challenging for me and I'm feeling this way working with him, imagine what it must feel like for Larry, who wants to make a piece of toast in the toaster oven and has to deal with these things. You know, they affect him on that level all the way up to his recovery from substance abuse and mental illness. And you are only seeing it from a few different perspectives, and he's got to deal with it from every perspective. So that's a big one, and that's one that I'm particularly in tune with from my previous work on the research study that I've talked to you guys about, related to cognitive remediation. So I worked with college students with mental health issues, not necessarily substance abuse. You had to have mental health issues, and worked on improving attention, improving focus, and concentration. So a lack of social supports. So for many of us, if you're feeling particularly stressed out, you know, had a shitty class tonight, it's like, oh, man, that Derek. So glad I don't have to look at him for another week. You go home and you vent to your significant other or your friend or your parents or your sister, brother. You know, you go out to have a drink after class and chill out with your classmates and talk about how evil I am. It's like, you have that social support. You can commiserate together or with some family or friends. And a lot of times the people in those most challenging, the most difficult people to engage, one of the reasons they're this difficult is because they lack these social supports. So they don't have anybody to vent to. So what happens? It builds up. They find unhealthy ways to manage it, you know, and it presents itself in destructive behavior or high risk types of stuff. So, you know, sometimes I think we take our social supports for granted. Consider people that have none, you know. Trauma history. So we've talked about intervention in the past, and that's kind of where I see it. A lot of those people that end up being on that show, a lot of times kind of been sort of treatment resistant in the sense they've tried other things to get the person clean and they haven't worked. And oftentimes the story unfolds if you've watched intervention. And one of the common themes I see among so many of the people on that show is a history of trauma, abuse, from a parent, or sexual abuse or molestation, you know, some kind of traumatic event that triggers, or, you know, people kind of trace it back later on. It's like something changed after this, you know, and it often manifests itself in these types of high risk or really dangerous types of behaviors involving drugs and alcohol. Valerie, yes?
This might be off the topic, but if you put intervention. When you're watching the hoarding shows, right?
Yeah.
Is there any research that shows those individuals would have co-occurring disorders just because they would have to deal with the mental illness or, well,
Okay, so you guys know the show she's talking about? So I used to follow intervention, I remember, at a time. I don't watch hoard. I watched it in the first couple of seasons, and then I stopped because it was like too close to home. Like I would see, it would be like, that's like the person I'm working with. And I remember I could never watch intervention and hoarders back to back because it was like too much mental, like, it's like, no, like the issues that they dealt with were too close to the issues I was working with people dealing with on the job. So it was like, I stopped watching it. So the major difference, number one, not nearly all the people on hoarders have a substance abuse issue, right? Some might, but the primary diagnosis on that show is what? Mental illness, specifically what kind? And what is that? Yes, OCD. Now they might have other types of diagnosis in addition or in place, but that's the typical one, just like we see such a prevalence of PTSD in this population. So that's sort of one similarity I see, is like the commonality of what the diagnoses are. That show, I mean, that's tough. I really credit the people that work with people that have OCD on doing exposure therapy. You know, if somebody has agoraphobia and is afraid of going outside, exposure theory is, let's put you outside and deal with this discomfort and talk about how it makes you feel, and talk about, because the longer somebody sits with that anxiety, it begins to pass and people start to learn how to sit and deal with that discomfort. That's a really hard thing to do. And those professional organizers that go into those places, like, whew, they must earn their money in gold, because I could never do it.
Some of them do.
Some of them do. Some of them do. They're very brave.
No, I see that they have their own like cleaning team that
Yeah.
goes in there.
Yeah.
I guess the specialist visit, the
Yeah.
initial visit, but I've seen things where they had like teams of 25, 30
Mhm.
people going in there. And they don't attack it in one day. That's how much stuff is in the house.
Yeah.
I'm like, okay, that's what I'm saying. It has to do with mental illness somehow.
Yes. So the most usually that common feature of that, the symptom of hoarding, collecting, and often is rooted in some kind of OCD diagnosis. Poverty. We talked about this with the article, right? This idea of like, is a lack of income kind of the central issue with a lot of these cases that relate to housing or lack of employment or lack of social support. So I won't spend too much time on that. And then in general, just poor motivation. I remember one of the most challenging people I ever worked with. He drove me just up a wall. I still think about him now, and I'm just like, oh, that guy. Man, that guy. And the biggest reason out of all of these was this one. It was like, that guy didn't want to do anything for anybody. And it was really a situation of him being in the wrong type of service, Talk about an involuntary situation. The guy did not want to be there. Didn't want to be. It was a partial care program. He was there because his housing program made him go there. So he'll be damned if he was going to do anything I wanted him to do. And we had to go through a lot of the, individual talks, and he would be the one that, I'll do this tomorrow, starting tomorrow, all new, turn over a new leaf, anything I wanted to hear. And in the back of your mind, you're thinking, he's not going to do this. And so often it did not happen. Okay, so those are some of the extra special issues that you guys will have to deal with when you get out there. But you can't wait. One of the ways we can work through this is that acknowledge, in a lot of cases, not all, you can acknowledge the people that are doing the best they can. And you can see that, right? You can see it when they're making an effort as compared to somebody that's not making the effort, right? I mean, I could see it in you guys. You work with people, you get to know them. When you have a sense of what people are capable of, you can see when they get something that's a little less than their best work, right? And that would be in recovery too. Be like, hey, you've been kicking ass for the last few weeks on this, and now I've noticed in the last week, things have slowed down. Like, what's going on? It's like, you're right, and that is what's happening, but it's because, I got this other thing going on. It's like, oh, I'm really glad I mentioned something to you, because it makes me see how much resolve you have to get through this tough situation, because I see you doing the best you can despite, this extra barrier.
I want to add, a lot of people don't acknowledge you're doing the best that you can.
Absolutely.
Not just in this field, in general.
Yeah.
They feel like, oh yeah, you're supposed to do this, and if you fall short, you break down as a person.
It's a question.
Like, oh, this was my best.
Right. And the other person that's doing the judgment is saying, why haven't they done this? It's like, well, it's obvious to them, or they must be lazy, or, they must not know what they're doing or whatever. And it turns out that's just what they're capable of right now. And when we talk about, the strengths focus, that principle of psych rehab, this slide isn't doing anything weird, is it? It's not moving. Okay. No, it's awful. Yeah, it's pretty bad. Yep. Makes you miss my old red and white, no icon kind of PowerPoint approach, huh? So what can we do? What can we do? So in order to avoid frustration, so sometimes we need to take a more creative approach. It's like frustration, it's like we've tried this certain intervention 3, 4, 5, 17 times. Let's try something else. Let's consult with some people in other programs or other people that have worked with this individual in the past, or, let's get a fresh perspective. Certainly returning to that hopefulness, and in some cases it might require some time away from the situation to kind of come back recharged and hopeful again. And that is, like I was kind of saying, is like the necessity of those mental health days in the field is warranted for these reasons, because you may need that. You yourself need to be energized in order to energize other people. Yes?
Yeah, I wanted to add that. I guess, we're students or whatever, but me, when I get overly stressed out, I thank God that I could go to sleep to re-energize myself.
Mm-hmm.
I'm like, if there was no sleep involved, I would be
Right.
climbing the walls.
Right.
I know that.
I think about when I'm stressed, being around other people that are stressed and it making me more stressed out.
Right.
So I'll seek out people that are very calm. And it's like, thank you for being so calm right now, because it's making me calmer, So, I think about this as a teacher too. It's like if I show up and I'm in a bad mood, or if I'm just kind of like, I don't really want to be here, you guys will probably figure that out, right? And what will happen? Probably won't be as energized, won't be as hopeful about doing well in the class or feeling good about it. So it's up to me to kind of put on that persona. And we have to do that for people we work with too. And that's why when we don't have it in us to do that, I'm going to get to that. When we don't have it in us, that's why when we need to do something else, get some extra support, take a day off, whatever, to sort of get back to that status. Yes.
Well, going into the field, I don't know if that's something I need to fix before I get in there, because you're supposed to be a motivation for the people you serve. But me personally, I always feel like let people go through that time in their life so they could understand, I could pull myself out of it.
Mm-hmm.
And I want to be mad. Let me be mad.
Yes.
And then it'll, progress into
you mean the people we're working with, or you as the practitioner?
I mean, you and the people you work with.
Yeah.
Because you have to work on yourself before you telling me,
yes.
You can do it, everything is good. If you can't do it as an individual or
that's right.
professional,
you can't model it to other people. That's right. So if you're feeling just really down about things or not very hopeful, sometimes you can, put it aside and, but sometimes you can't. In those cases, it's like, you got to get to the root of that problem before you're going to be able to help anybody else. So, okay. So a long-term perspective. So a lot of times we want the progress to be like, it's now, right? This support plan was for 3 months. And in these last 3 months, look, nothing has happened. We haven't gotten any of these interventions accomplished. And that I could totally relate to. Talk about it. What happened?
No, it's just, I admit I'm somebody that has that characteristic. If I don't know what's going on right that minute, I go bump. You know what I mean? It's like, if something that I gotta do has to get done at a certain time, and it's not done on my time or when I think it should be done, even if it's something that the other person is doing, I have to fight the urge to be like, and then you don't want to do that.
Right. So this idea that we need to take a long-term perspective is hard. Say, all right, we haven't seen any progress in 3 months, and especially when we have other people above us sort of demanding answers, right? And that might be a supervisor being like, so why hasn't this person made any progress in 6 months? And you got to come up with, and justification or whatever. Or sometimes it comes from like Medicaid or the division. It's like, so this person's been in your program for X number of years. What are we doing here? You know, are they going to be moving on? And sometimes the funders themselves can't take that long-term perspective that is required in this field. So I can relate. Did you want to say something else? No? So IDDT, integrated dual diagnosis treatment, works when people do take a long-term perspective, or I should say it works better. But there's recognition that it's oftentimes years, not months, that we need to be looking at the time frames is a bit of a bitter pill to swallow, right? Like, but think back to a major change you had to make, right? Yeah, it doesn't always take just months. Think outside the box. So this one can be sort of, yes, I agree, and yes, we need to try new things. But we need to balance that with having tried things that are empirical or evidence-based, right? So the natural tendency the first things we should try sort of should be the things that are have been shown have sort of positive outcomes, things in line with the mission of your organization. But then sometimes, like I said, we get frustrated. The same 5 interventions that work for 90% of the people we work with aren't working for this 10%. Now it's time to get a little creative and say, all right, what about this? You know, let's try it, you know, because we're doing our people we work with a disservice when we just sort of give up. And when I say give up, I mean, it's not like we stop working with them, but it's like we stop trying new things. It's like, let's just keep doing the same thing because this is all we know how to do. Keep bringing them to 12-step groups. And it's like, it's obvious the 12-step isn't working. You know, it's like, you know what? We need to pull out a different tool out of our toolbox then. Dust off one of the tools you haven't worked with in a while. Yes, it's an analogy, but it might equate to, it's like, oh, we haven't used this group in the community for a while, but maybe it would work with this particular individual. Collaborate. Again, this could be other providers. This could be people that have worked with the individual in the past. This could be family or friends or the few supports that they do have. And then functionality. So think in terms of functional status, not just checking off boxes, so to speak. Functional status is actually what can now people do? What are the skills? Being proactive in not waiting for things to come to us, but, you know, kind of offering them up to people to say, hey, have you thought about this? You know, as opposed to waiting for the person to bring it up to you, and developing goals based on those things. So some strategies for dealing with burnout. We're now going to transition into the Drake article, which doesn't deal with burnout at all. So it might be an odd transition. Let me just pull the article here. Okay, so the title of this article, 10-year recovery outcomes for clients with co-occurring schizophrenia and substance use. So this was done by Robert Drake, and et al. Through Dartmouth. And so don't see too many studies that go on for 10 years. Call that a longitudinal study. Why do you think we don't see them? And I'm not talking about just in this population, I'm talking about in general. Yeah. So the longer the study goes, the more potential you have for what we call attrition, you know, people leaving the study or being lost. And also with staff following the people too. You need to fund people to continue to work for 10 years. That usually is very cost prohibitive. We just, to give you some context, the grant that I worked on for cognitive remediation was $900,000 we got for that grant for 3 years. So it was $300,000 a year. And that was a decent sized grant that came from the Department of Education. It was like the top group. So that was for 3 years. So let's see, if you wanted to do that study for 10 years, you would need more than $3 million. You know, a little bit harder to get. So it's hard to get funding to study people for this long. But yet, what did we just talk about with burnout? A long-term perspective is needed, right? And so if we don't study people long-term, it makes it so much harder to take this long-term perspective because we don't know what actually happens when we study people for that long, right? We said recovery can take years, right? So what happened when we studied recovery for 10 years? Let's find out. So what did we want to know? Drake wanted to know, is recovery multidimensional or not? And does recovery improve after 3 years of integrated dual diagnosis treatment? What do you think? Is recovery multidimensional? I don't imagine most people have read the article yet, and that's fine. It wasn't assigned. But speculate. Yes, you do? Okay. Yes. I'm going to give you the hint. It is multidimensional. Does recovery improve after 3 years of IDT? Anyone want to speculate? Yes, it does. Shh, don't tell anyone. Okay, let's find out. All right, so I don't know. Is recovery multidimensional? Here's what we did. Here's what Drake did. So they recruited participants from New Hampshire. They were in community mental health centers throughout New Hampshire. So they were already engaged in treatment. It wasn't like they pulled people off the street. And everyone in this study was diagnosed on the schizophrenia spectrum. The majority, they fell into two categories, either basic schizophrenia or schizoaffective disorder. They did a randomized control trial for the first 3 years to receive IDD treatment. So one group got assertive community treatment, and the other group got standard case management, okay? So they followed people for 3 years. They looked at them every 3 months, and then after 3 years, they looked at them yearly and used a variety of tests. So I don't remember if this was specified directly in the study, but what it seemed to me was that initially they just were thinking about studying people for 3 years. And then at some point along the way in those 3 years, they're like, oh, you know what? When this study is over, let's actually continue it and see what people look like 10 years out. I don't know for sure if that was the case going in, if they knew they were going to be doing the study for 10 full years, or if they were only thinking in terms of the 3-year study initially or not. So what kind of tests did they use? Oh, not yet. What kind of tests did they use? You will look at that study and see a multitude of tests you recognize. Let me just get them. I had them on my other slide deck here. Measures. Okay, so these are the things that the study staff used on the individuals. So they did a structured clinical interview. This was based on the DSM-3, 3R. So this is, again, back in 1990. They used the timeline follow back. Does that sound familiar? Yes. To assess days of alcohol and drug use over the previous 6 months. They used the Addiction Severity Index, the ASI. Oh, we learned about the ASI. They used the Quality of Life Interview. So that was not one we discussed specifically. It's not specific for substance abuse. It's used in other types of studies as well, but it assesses objective and subjective dimensions of quality of life. They used the Expanded Brief Psychiatric Rating Scale, the BPRS. Sean and I know this document well. It's an instrument that we used in our executive functioning study to basically see what people's symptoms are. So it looks at a range of different subscales, you know, how depressed somebody is, how hostile they are, how suspicious or paranoid they are, how anxious they are, what's their thought patterns. So this is the Brief Psychiatric Rating Scale. The BPRS is looking at the last 2 weeks. So it's really just the short-term mental health status. They also used the alcohol use scale and the drug use scale. The AUS and the DUS should be ones you remember from the Meuser text. They also used the SATS, S-A-T-S, Substance Abuse Treatment Scale. And they also used urine screens to confirm drug use, the presence of drugs and alcohol in the system. So that was another instrument that they used. So a bunch of these instruments are ones that we actually talked about in class and used. Okay, so when they administered these, what did they find? After 10 years, IGDT worked! Oh my goodness! 65% of the people did not have a substance use disorder. People had increased their employment rates. People had perceived increased quality of life. They found recovery to be multidimensional. And people recovered. So this reminds me, as I was reading this study, it reminds me of the Vermont study. You guys remember the Vermont study from 1101? It was talked about then, where it was another longitudinal study that studied people, I think, 30 years, if I'm not mistaken, and found similar things. They weren't looking at substance abuse. They were looking at straight mental health and looking at people discharged from state psychiatric hospitals and followed them for 30 years. And they found the long-term course of schizophrenia was hopeful. People got better over time. The end. Yes?
When you say that 65% of the people had no substance use disorders, do you mean that they weren't using, or do you mean
Good
they
question.
couldn't use and
No, that's a good question. So I had that on my slide. I had specified that. I almost think I want to go back to my slides and just look at a couple more things. So 65% had no signs of abuse or dependence. So think about the DSM when you look at those different criteria. So 65% had no signs, but 39% had been abstinent for at least 6 months. So 25% had used in the last 6 months, it seems like, but had no signs of abuse or dependence. So they used casually, like you or I might. You know, it's like,
percent use casually?
well, it says 65 had no signs of abuse or dependence. 39 had been completely abstinent. So the remainder of that, the difference, had not been abstinent, but also had no signs of abuse or dependence. All right, so they used in moderation, is what it looks like. Okay. I want to go to the discussion here because there was a portion I wanted to read. All right, so I'm just going to read this because it summarizes it better than I could just summarizing the summary. So the 10-year outcome for participants with schizophrenia and co-occurring substance abuse were positive for large proportions. Despite severe and prolonged disability, many of these individuals were able to control these disorders, control both the disorders, reduce episodes of hospitalization and homelessness, live independently, achieve success in several aspects of community functioning, and attain what they perceive as a better quality of life. So not only did participants continue to improve in outcomes between year 3 and year 10 in most areas, they also improved in some areas that had seemed static at 3 years. So think about that, right? For the first 3 years, in certain areas, like there was no progress. And people were like, guess it doesn't look that hopeful. And then then they look at year 10. It's like, actually, those areas in the first 3 years that didn't really move ended up moving in the positive direction. Amounts of activities, social contacts, and family contacts actually decreased as participants learned to manage mental illness and substance abuse, and as they attained independent living, employment, and friendships with non-substance abusers. What do you guys make of that? So that they actually had less social contact over time as they learned and recovered. What?
No, I said that sounds conflicting.
It would sound conflicting at first glance, but when you think about it a little more, it's the goal to live independently. They may have needed a lot more contact, and now they depend less on others because they have a bunch of self-control and self-strategies that they can use instead of relying on other people. And think about it, as we get older, do we spend more time with other people or less? We spend less time with other people. We're more social as younger adults. So it makes sense that just as we get older, our social contacts, decrease. Not everybody, but generally speaking. So that's why it's actually not so surprising when you think about it. The concept of mental health recovery continues to be difficult to define and measure. That's not surprising, right? For the current analysis, we have taken the position that recovery outcomes should correspond to meaningful behaviors identified by dual diagnosis clients themselves. I agree. That's what we talk about functional improvement. For example, people with co-occurring mental illness and substance abuse report that having regular contact with friends who do not abuse substances, rather than increasing the size of their social network, is a meaningful social outcome. That makes sense to me. So let me summarize what that means. A lot of times, practitioners might be saying, you need to make, to increase your social network. You need, to make new friends, as you engage in your recovery. And what they're saying is, no, I just need a couple of really good friends that don't use drugs. I don't need a lot of friends. I just need a couple of really good ones that are good influences. And I think that if I were in that case, that's what I would need too, more than a bunch of casual acquaintances. We use clients' advice to select recovery outcomes, but we readily acknowledge that the operational definitions used here were idiosyncratically determined by the clients who collaborated with us on the study, and were limited by the variables available in our data. So they went with what people were saying and didn't do much in the way of statistical validation of that. But they found these six recovery outcomes that sort of go throughout the article, and I'll just mention them briefly. So to assess here's the reason they had to pick these outcomes. How do you know what recovery looks like? When you're trying to measure something like recovery, it's very difficult to say, oh, well, Amanda recovered 30%, but Faye only recovered 20. How do you assign numbers to recovery? It's hard to quantify, right? It's hard to measure. So the way Drake et al. Measured it is they looked at these six constructs. So they looked at psych symptoms. So did psych symptoms decrease, right? So if somebody is experiencing depression 80% of the time in their life, and they're able to decrease that to 50% of the time, that's a decrease in symptoms, right? Makes sense. But how do they measure that? Nope. How do they measure in that one individual that their symptoms went down or up? They did. And what tool did they compare? Remember those tools we discussed? It was the BPRS, the Brief Psychiatric Rating Scale. So think about it. I'm a practitioner. Right. So maybe at year 2, I administered that to you, and you're like, oh, I'm really depressed, super anxious, really paranoid. And then 5 years later, I interview you, and you're like, no, actually, it's gotten a lot better. I'm still depressed, but only once a week, not 7. It's like, and now there's a way to score that rating scale and to come up with a number. And it's like, oh, now if you're at less than 3, it's not what you would call, clinical or severe or something. So that's how they determined symptoms. The second thing they looked at was, did people reduce their substance use actively? Not say, oh, I'm going to quit, I'm going to reduce it, but actually take active steps. And the way they measured that is, did people attain late active treatment stage or better? So do you remember the Dolly? When they broke it out into the different stages. Each stage had like early intervention or early engagement and late engagement. So they're saying that they needed to attain late active treatment, which is pretty far along, right? That's somebody that's achieved some amount of abstinence, that's actively working and engaged in treatment. And the way they quantified this is that other one, the SATS, Substance Abuse Treatment Scale. If they scored above a 5, that indicates the individual has attained clinically meaningful remission and is actively pursuing long-term abstinence. So again, it comes back to comparison, right? Oh, in year 2, my score was really low because I was abusing drugs every day. 5 years later, oh, I'm doing a lot better with that now. My score is much better. So these are the recovery outcomes, just to summarize. So lowering of psych symptoms means somebody's, recovering. Actively reducing their substance use. Number 3, achieving independent housing. So not living on the streets and not living in a hospital and not living in jail. People that are able to achieve independent living had a better chance of recovery. Not surprising, right? Based on what we talked about. People have a firm home that they can call their own, that is safe, that they know is theirs. They probably have a better chance of now moving on to manage the other things in their lives that are giving them trouble, that they need that foundation. So the way they determined that was, did they spend 80% of their days residing in their housing? They allow for some relapse, I did need a week in the hospital in this month or whatever, but if they're out of the hospital and in their own home, 80% or more of the time, we're saying they achieved independent living. So that's number 3. Number 4, competitive employment. Not surprising also, right? Somebody had a job, they're more likely to recover after 10 years. I won't spend too much time on that because we have talked about employment enough. But what they determined is competitive employment, a job in the past year, minimum wage or better, and it is their own job, not a job that the agency gets and gives to them, right? So it can't be like sheltered employment. It can't be TEP, Transitional Employment Program, through Clubhouse. It's got to be real competitive employment, earning a legal wage. What? The second one? The second outcome? Decreasing substance abuse, decreasing active substance abuse. So it was lowering symptoms, decreasing substance abuse, maintaining housing, obtaining competitive employment. And we have 2 more. Regular contact with friends who do not use substances. So think about it, right? You're an active user. You probably are not spending a lot of time with other people that are not users or abusers. It's just the way the sociability of drug use goes. So if people are finding that they have 1 or 2 or even more people that they're really close to that don't abuse or use substances, they have a better chance of recovery themselves. Makes sense, right? And that's one that maybe, in my mind, I don't know if researchers would have jumped on that one immediately and been like, this is a really important outcome that we need to look at. I imagine that might have been one that came from the people themselves saying, this is important. You need to track this. So that was another key aspect. And then the last one, quality of life. So as time went on, quality of life generally went up. People perceived that their life was better overall in year 10 than they did previous years. And that they used, as I mentioned, there was a quality of life interview. And so if they scored at a certain score, they had determined, they had good quality of life. So this was a really interesting study. And I encourage you to read it. Any questions? What time is it? Perfect. All right, so in closing, in going through the final, I'm going to be really looking closely at the final tomorrow. But in glancing at it today, I could say that obviously you should know everything. But, well, I was talking about it with Sean today. It's like the elements of this course kind of flow throughout it. So I guess it's cumulative in that there are elements from the beginning that are stressed in the end, but it's things like stages of change and stages of treatment that are foundational to the entire curriculum. So, so if I had to tell you what to focus on for this final exam, I already told you motivational interviewing is going to be featured heavily. So it was not featured at all in the midterm because we hadn't really started talking about it yet. So we will be quizzing, we will be asking you a lot about motivational interviewing. Other than that, know the stages of change and the stages of treatment. We've talked about them ad nauseum this semester. I understand that having two separate scales that seem so similar can be confusing. But if you know those scales backwards and forwards and the difference between the two and what are the components of persuasion, what are the components of, you know, each of the stages of treatment and each of the stages of change, you should be able to approach just about any question on here with a good amount of, you know, even if you don't know the answer, a good amount of background info enough to make a good educated guess. Yes.
You had at one point started like with the first screen of the violence and medication adherence PowerPoint, and you never put it up.
It's on Moodle.
It is on Moodle. Yeah. Okay. So
Check again.
Did you go back and look through that?
There will be a couple of questions on the articles that were read over the course of the second half of the semester, because I don't think we started with articles until after the midterm. So that, you know, they are fair game. Like I said, Rosengren, you know, that text has all the motivational interviewing and stuff in it. So know those concepts, you know. And then from Meuser, specifically stages of change, stages of treatment. Any questions? All right. Well, guess we can go home.
Thank you.